Hello everyone, welcome to the McMaster Clinical Skills Radiology series for today's lecture on bone lesions, aggressive versus non-aggressive lesions. This presentation is created by myself, Vishal. I'm a PGY4 McMaster Radiology resident, and with the help of Dr. Danielle Walker, who's a staff radiologist at the Hamilton General Hospital. The main goal of this lecture is primarily to help you identify what the features are that make a bone lesion aggressive and non-aggressive. It is not necessarily intended to have you be able to come up with a diagnosis immediately after seeing a bone lesion. So I would avoid, the tendency to try to lean towards making a spot diagnosis on a lot of these lesions, especially because in a lot of cases it's not possible and there is a differential diagnosis for a lot of these appearances. So again, just to reiterate, the main focus is to help you identify what the features are that make lesions aggressive and non-aggressive when we're looking at bone radiographs. So with that said, let's get started. So first, just to go over some of the terminology and why we classify things as aggressive versus non-aggressive and why we use that language. We use it basically to describe the most worrisome features on radiographs that we see related to the lesion. And we generally avoid calling lesions benign or malignant, and that's based on the radiographic appearance alone. We don't want to come down on something as benign or malignant just based on how it looks on a radiograph. And the reason for that is mainly because aggressive lesions can often be benign. For example, if you have a severe osteomyelitis, it can look very aggressive, but we know that that's benign. It's infection. And then non-aggressive lesions can also sometimes be malignant or have malignant potential, especially slower growing malignancies. So unless there's a very classic radiographic appearance for something and you have a good clinical context and you have a multidisciplinary approach to it, in those cases, sometimes it's okay to call something benign or malignant. And oftentimes, however, you're going to have to provide a differential diagnosis, which is usually more helpful, and you can include both benign and malignant lesions where appropriate. In terms of the radiographic classification, we characterize bone lesions to help narrow down our differential diagnosis. Location and patient age are essential considerations when you're interpreting a radiograph and when you're giving your differential diagnosis, because these can drastically change what your differential is and what these lesions can be. The main descriptor categories that we use on radiograph and what we're mainly going to focus on today are these four here: margins, the margins of the lesion, the cortical expansion if it's present, periosteal reaction, and the matrix. The main ones to pay attention to are the margins and the periosteal reaction, which are key in differentiating aggressive and non-aggressive lesions. These pictures are just some examples of some of these descriptors. This one's just showing a very well-marginated lesion here, a little bit less well-marginated, and even less well-marginated, kind of blending with the adjacent normal bone over here. This picture is, again, showing something that's very well-marginated. This picture is showing what periosteal reaction can look like in different cases and shows the relative aggressiveness of different types of periosteal reaction, but we'll dive into each of these in more detail. So first we'll start with talking about the margins. This is arguably, the zone of transition is a type of descriptor of the margins, and it is probably the most important descriptor in determining whether or not a lesion is aggressive or non-aggressive. The zone of transition indicates the growth rate of lesions. So basically, if you have a narrow zone of transition, that means something is very sharply marginated. It has clearly defined boundaries between the lesion itself and the adjacent normal bone. You can clearly distinguish where the lesion ends and where the normal bone starts. And that's what we call a narrow zone of transition. When you have a wide zone of transition, the distinction between the normal bone and the actual lesion is hard to tell. You can have a blurred or poor distinction between the boundaries of the lesion and the bone, and that's what we call a wide zone of transition. You can have a spectrum of the zone of transition, so you can have something in between a narrow zone and a wide zone, and you can say the zone of transition is kind of intermediate. But for the purposes of this talk, we'll focus on the kind of ends of the spectrum. Generally speaking, a narrow zone of transition we consider non-aggressive, and a wide zone of transition we consider aggressive. That's the key point here. And this makes sense in terms of aggressiveness. If something has a wide zone of transition, it means it's growing quickly into the adjacent bone, and that's what we see radiographically. The distinction is poor between the normal bone and the bone lesion. And the opposite is true for the narrow zone of transition. If something's growing very slowly, you see kind of a better distinction because it's, not infiltrating that bone as quickly. And we'll look at some examples of this. So here's a really good example of something with a narrow zone of transition. You see a very well demarcated lucent lesion in the bone here in the distal femoral metaphysis. It has sclerotic margins as well, which we'll talk about a bit later. But the main point here is to focus on the margin and see how you can see normal bone on this side, and immediately you see the abnormality right here. So again, narrow zone of transition in this lesion is suggestive of a non-aggressive pathology. This case was actually a pediatric patient, and this was this is what we call a non-ossifying fibroma. It has a pretty classic appearance here. You can see it's eccentrically located, sort of near the cortex, and again, very well marginated, narrow zone of transition, lucent, sclerotic borders. Peak age, this is actually the most common benign bone tumor in children, and the peak age is at 10 to 15 years old. Here are some examples of what a wide zone of transition looks like. These are 3 different patients with 3 different pathologies occurring. But if you look at the first one, you see it's a very ill-defined lesion in general. It's mixed sclerotic and lucent. But again, the main point we're focusing on here is you can't really tell where this lesion starts and where this lesion stops. You can see maybe some normal bone here, but it's patchy. It's, again, lytic here. You can't draw a margin around this lesion and say exactly where it is. You see some cortical destruction here as well, which is another feature that we'll talk about. The same goes for this lesion here. A little bit easier to see where the lesion is on this picture, but again, very difficult to draw a sharp pencil around the exact margin of the lesion. It's kind of blending in with the adjacent normal bone, especially up here. Here also we see some cortical destruction, some periosteal reaction. And then this lesion here, same idea. Margins are difficult to delineate. It kind of blends with the normal bone. And so the first case was actually an example of an osteosarcoma in a patient. This one looks like it was osteomyelitis, and this one eosinophilic granuloma. As you can see, the lesions kind of look similar in terms of their lytic and sclerotic mixed appearance. And it's difficult to, come down on a spot diagnosis on each of these. You can't actually. And that's why it's important to find a differential for these aggressive lesions. So again, all 3 of these are aggressive. Only one of these, the osteosarcoma, is actually malignant. This one's an infection, and this one's an eosinophilic granuloma, which is basically a bone manifestation of a disease in mostly pediatric patients called Langerhans-Stahl histiocytosis, which is beyond the scope of this talk, but just something to show the aggressiveness on these 3 images. And then margins can be further characterized based on their geographic and non-geographic appearance. I don't think it's necessary to go into detail on these, except to know that geographic lesions are generally round or oval in shape. They can have sclerotic or non-sclerotic margins, or they can be more ill-defined. And then non-geographic lesions tend to be more aggressive. And the descriptors we use for these are moth-eaten and permeative, which can be difficult to distinguish, but we'll look at some examples. And just one thing to keep in mind, that even if you have a geographic round or oval lesion, it may still have a wide zone of transition, which would characterize it as more aggressive. So here's some example of geographic lesions. These are round or oval in shape. You can tell very nicely marginated. They both have very narrow zones of transition, as you can trace them. This one over here has some suggestion of some sclerotic margins at the periphery. And this one over here has relatively non-sclerotic margins. And the image on the right here was a case of a chondroblastoma in an 18-year-old male. And the case over here was a giant cell tumor in a 20-year-old male, both benign lesions. These are examples of the non-geographic margins we mentioned. So this one over here is an example of what a moth-eaten appearance looks like. You can see these kind of punched out holes. There's multiple of them. It's kind of a pattern that's like extending over a long area in the proximal humerus. So again, moth-eaten appearance, non-geographic pattern. And this was an example of multiple myeloma in a patient, a 74-year-old patient. This one is what they call more of a permeative pattern. It looks like it's more infiltrative and diffuse in the bone, no discrete sort of punched out lesions that you can identify, but this is what we call a permeative pattern. This one was in the femur, and this was an osteosarcoma in a 27-year-old female. Making the distinction between moth-eaten and permeative is not that important. The important thing is to recognize that it's an aggressive appearance either way. And it can be challenging to differentiate the two, and I don't think it is that important for our purposes for this talk. Cortical expansion is another area that we'll talk about now, the next descriptor. So generally, cortical expansion implies slow growth of a lesion and is a non-aggressive feature, and this is a general rule. However, you want to make sure there's no cortical destruction involved with it, because that could suggest a more aggressive feature. Lesions are usually benign, like I said, with a few exceptions. There's a low-grade chondrosarcoma and certain metastases, like from renal cell carcinoma and thyroid cancer, which can show, cortical expansion, but still be, malignant lesions. So here's some examples. This is a lesion showing some cortical expansion. If you look at the posterior aspect of the tibia here, it's kind of bulging out like this. So this is an example of cortical expansion, and the lesion here is cortically based. This was another example of a non-ossifying fibroma. Here's an example in the proximal femur. You see that the cortex is, take my word for it, but this cortex is, this cortex is expanded. It's a little bit wider than you would normally expect in a proximal femur. And you see this kind of ground glass density throughout. This one was an example of fibrous dysplasia, which shows cortical expansion characteristically, and basically it's a failure to form mature bone here. You can have monoostotic or polyostotic, which just means more than one bone involved in the polyostotic case and one bone involved in the monoostotic case. If you have the polyostotic form, you may have heard of McCune-Albright syndrome, which is associated with it. Not all cases of polyostotic fibrous dysplasia will have McCune-Albright, but McCune-Albright is also associated with other things like cafe au lait spots on the skin and precocious puberty, but that's beyond the scope of this talk. Here's another expansile lesion in the proximal femur. You can tell this is a pediatric patient because the growth plate is not fused, and you can see the apophysis here at the greater trochanter. But this is an example of an aneurysmal bone cyst. It's sometimes said to have the soap bubble appearance, and it's clearly expanding, causing some cortical expansion here. So this is just a slide to say, there are exceptions for cortical expansion. They're not all benign, so don't be fooled. This is a case of an RCC metastasis, or renal cell carcinoma metastasis in the distal femur. And you can see it's causing cortical expansion. It's a lucent or lytic lesion right here. There's some suggestion of some possible cortical destruction here, which would make you think it's probably more aggressive. And this is another example of an RCC metastasis showing some cortical expansion. This diameter is a bit wider than you would expect. But the main point is that you want to really consider the clinical context of when you're interpreting these bone lesions, because if you know the patient has a history of RCC, your suspicion is much higher that this is going to be an aggressive, or sorry, not aggressive, but a malignant lesion, possibly a metastasis from their RCC. The other thing to consider is whenever you see a lytic lesion in an adult or a patient older than 40 years old, you always should consider metastasis in the back of your head. And sometimes it's important to always include it in the differential diagnosis. Now we'll talk about another descriptor, so periosteal reaction, another very, very important descriptor in terms of determining aggressiveness. So periosteum is essentially a thin layer of fibrocellular tissue, and it's located on the outside of the bone. This is just a diagram showing you where the periosteum is on the bone. So this would be the osteocytes in the cortical bone, and this layer here would be the periosteum. You have a fibrous layer and you have a cellular layer, which actually lays down new bone. The fibrous layer is like the connective tissue part of it. And the periosteum has vessels and nerves, and it helps nourish and repair bone. What we call periosteal reaction is essentially bone formation along the cortex where the periosteum is. Basically, it means the periosteum is forming new bone in response to some kind of either tumor, it could be infection, or it could be trauma. So that's what periosteal reaction is. And you can have different types of periosteal reaction, and they can suggest different things. So you can see that there's a kind of a spectrum here of non-aggressive to aggressive types of periosteal reaction, and these are different kinds. If you have this nice solid periosteal reaction, that's non-aggressive. Usually this is associated with like healing fractures, unilamulated and multilamulated, kind of progressing in aggressiveness, and kind of suggests to you that something's growing there and kind of laying down this new bone at one point, and then it's growing a little bit and laying down some new bone. And then if something's growing really quickly, you can get this spiculated periosteal reaction, which is kind of bone forming along these things we call Sharpie's fibers, which attach the periosteum to the bone. And then another thing called Codman's triangle, where you kind of have a lifting off of the periosteum, which is a very aggressive feature. Sometimes you can have buttresses, but we won't talk about this right now. Just for the purposes of this talk, we'll keep that aside, but these are considered benign. So here's some examples of different types of periosteal reaction. This one, you can see very clearly this periosteum is lifted right off the bone. This is a perfect example, really good example of a Codman's triangle. Here along the margin of the bone, you see some spiculations as well. This is spiculated periosteal reaction, or possibly some new bone formation. And this was an example of an osteosarcoma. Here's an example of a more lamellated appearance of periosteal reaction. You can kind of see like a line here and then a line here, and they also seem interrupted. This lamellated appearance is also called onion skinning or onion skin, and this case was an Ewing sarcoma. Here you have periosteal reaction that's a little bit more smooth along the border. It is kind of lamellated still, but it looks less aggressive compared to these ones, because it is so smooth. This was still considered aggressive, however, and this was a case of osteomyelitis. Moving on, you have, this is a very classic appearance of aggressive periosteal reaction. We call this a sunburst pattern, where you have these spicules radiating out, kind of like a sunburst. And this was a case of osteosarcoma. This is an AP view, and this is a lateral view, just showing the same case. So that's called sunburst pattern. And this was in the distal femur, so classic location as well for osteosarcoma. And this is another example of periosteal reaction, and another reason, just a reminder of why location is really important to keep in mind when you're describing your bone lesions. So this is located at the distal shaft of the fourth metatarsal in the foot, and you actually see a subtle fracture line right here, and you see some periosteal reaction adjacent to it. So just based on this location and the presence of a fracture line, even if you didn't see the fracture line, you know this is most likely going to be a reaction to a stress fracture. It's a very good classic location to have a stress fracture. Oftentimes, patient will present with their first radiograph, and when they first fracture it, and you can't see any fracture line, you don't see any periosteal reaction, but you re-image them at a later time, and you start to recognize some periosteal reaction, you may still see no fracture line, and you can suggest this is most likely secondary to a stress fracture. Moving on to the last descriptor category, we'll talk about the matrix of a lesion. So matrix is essentially just the substance of the extracellular space between the tumor cells. And it's helpful because you can actually use this information to identify the tumor type and narrow down your differential. Purely lytic lesions sometimes may have no matrix, so you may have nothing to, you can say that in your description, there's no osteoid or chondroid matrix present. But the types of matrix we'll talk about today are osteoid, chondroid, and fibrous. These are the main ones. And CT can be sometimes helpful to identify and characterize the matrix further. So first we'll talk about osteoid. So this is essentially, osteoid matrix is essentially the production of bone. So here's an example of a kind of a lucent lesion. You could argue that the zone of transition is maybe a little bit wide here. But overall, you can kind of, I would say, you can kind of make out exactly where the lesion is, but you have this kind of reaction around the lesion with increased sclerosis, which is an example of osteoid matrix. And this is a classic appearance for an osteoid osteoma. This one's located in the proximal fibular shaft. Classically, these osteoid osteomas have the central lucent nidus, which is this here, and then a rim of sclerosis or osteoid production around them. And these are typically seen in children and adolescents, and they're classically associated with nighttime pain in these patients that is relieved by using non-steroidal anti-inflammatories. This is another example of osteoid production in another patient. This one's in the distal femur. You can see definitely there's some other features of aggression here. There's some cortical destruction here, and kind of like maybe you could even say like a moth-eaten pattern here. Zone of transition, difficult to delineate, but you see this prominent, dense tissue here, which is actually osteoid production. And we know what tumors produce osteoid. Aggressive tumors produce osteoid, osteosarcomas. Yeah, and that's that case. Moving on to chondroid matrix. So basically chondroid matrix, these are examples of both chondroid matrix. This case was an example of an enchondroma, which produces chondroid matrix. And you can see this calcified chondroid matrix here. These are classic appearances. And this one is definitely more extensive. You can see it's extending into the soft tissues, and it's actually causing bony changes in the proximal fibula. This is an example of a chondrosarcoma. Now, just a note on enchondroma versus chondrosarcoma. Sometimes it can be very difficult or impossible to definitively diagnose these on a radiograph alone, and even on histology when the pathologist gets a sample of the bone, it's difficult for them to differentiate between these two. There are features that you can use to look for over time that change to determine whether this is transforming into a chondrosarcoma, but all of that is beyond the scope of the talk, and I would just stick to understanding what chondroid matrix kind of looks like. And then the last one would be fibrous matrix. So these are examples of both cases of fibrous dysplasia. Again, like we talked about, these ones are including the third metacarpal here and the proximal phalanx of the third finger. And it has this ground glass density. It's causing some cortical expansion as well. And this, like I mentioned, this is what we call ground glass density, and is a classic appearance for fibrous dysplasia. And this ground glass is actually the matrix that it's producing. So it's an osseous and a fibrous proliferation. You're not actually seeing the fibrous tissue necessarily on radiograph, but you're seeing kind of how it manifests with the osseous and fibrous proliferation. And that's what gives it this ground glass density. And the same here, you see this ground glass density. This is an axial CT of the skull, and you can see fibrous dysplasia can clearly involve the skull as well, causing cortical expansion. Very narrow zone of transition, you can see. It's sharply marginated. You can see exactly where the normal bone is and where the abnormal bone is. Just a note on location. So bone lesions do have characteristic bones that they develop in. Long tubular bones, flat bones, spine, and skull. If you see lesions in these locations, that helps you already narrow down your differential. So I'm just kind of trying to emphasize the importance of location. And bone lesions also have characteristic locations within the bones. So whether it's in the epiphysis, whether it's in the diaphysis, the metaphysis, whether it's centrally located in the bone, or whether it's eccentric, closer to the bone cortex. These are all clues you can use to help narrow down your differential diagnosis. I'm not going to go into details about all of these areas because it's a lot to cover, But just be aware, I think, being aware is enough at this stage that, different lesions affect different bones, and you can have bone lesions in characteristic locations in the bones. Here's some classic examples. This list is not exclusive, nor is it exhaustive, but just keep, you can read this later. You can pause the video and take a note if you want, or you can read further later. But in the proximal humerus, ABC or UBC is a classic location. In the distal femur, you always want to, consider osteosarcoma based on the features. In the pedicles of the spine, metastasis is a very, very important one to consider. And the flat bone in a child, you want to think about Ewing sarcoma. Flat bone in an adult, you want to think about chondrosarcoma. And in the calcaneus, you have these kind of classic lesions, a unicameral bone cyst, which is just also called a solitary bone cyst, an intraosseous lipoma, or a GCT, giant cell tumor. Here's an example of the pedicle that I was talking about. So in this case, you see a frontal radiograph, essentially, of the thoracic spine. And you see these little circles on either side of the vertebral bodies. These are actually projection of the pedicles when you're looking at them en face. And you can see they're bilateral, they're symmetric at every level here, but then you come down to this T11 vertebral body and you see the pedicle nicely over here, but you don't see one over here. This is a very important clue. It's called the winking owl sign. If you imagine that these are the eyes of the owl, the pedicles, and then the beak of the owl being the spinous process here in the center. You can see this owl here is winking at you because you can't see the pedicle, which is the eye. And then when you look at it on CT, on the axial CT, you see a big lytic lesion. This is the normal pedicle here, and you can see the lytic process is definitely involving the pedicle here. So whenever you see a missing pedicle or you see a lytic lesion in a pedicle, you want to always think about metastasis. And then just to comment on the patient age. So as I mentioned before, it completely changes the differential diagnosis. Some bone lesions are exclusively seen in pediatric population versus adults. And then bone lesions in patients over 40, you should always consider metastasis, especially if there's multiple. However, sometimes lesions may be characteristic enough that you can exclude this. And then just one last slide. I just want to acknowledge if you're interested in reading further and learning more about bone lesions, some really good resources. One is this website called Radiology Assistant. They have a nice webpage on bone tumors and differential diagnosis that will reiterate a lot of what we talked about. And then this book here, I have to say I used when I was in medical school and in my first year of radiology. It's called Learning Radiology, Recognizing the Basics by William Herring. And they also have a website with a lot of good information that you should check out. They have some good information on bone lesions. And then Radiopedia was an excellent resource, always for looking at specific cases and seeing multiple cases. If you're interested in any of the cases that were shown in the lecture, you can go and look them up and read a bit more about them. Most of the images were collected from Radiology Assistant here and Radiopedia in this lecture, but I included the sources for each of them in the appropriate slide. Thank you for your time, and I hope you learned something.